discuss transfusion trigger. Because blood transfusion per se, it's a costly commodity, it is somebody's organ. Okay, it is somebody's organ that is going inside, so it's not something that can be just bought from a shelf and then given. It comes out of a lot of effort by the blood transfusion, the entire department where they actually get blood from outside. And there are a lot of people, they take blood banks, store the blood, they take a lot of effort in fractionating that blood, plasma, platelets are produced because of that. So it's a big, Atul, hi, so Atul is right, okay. So it's a big kind of effort they take to get the blood. So that is the first thing, okay, that it's an organ that can be problematic. It's an organ that can be problematic to people. And why can it be problematic? Because an organ transfusion or organ blood transfusion like an organ transplant. So what happens with the blood transfusion? It comes with a lot of problems. Which are the problems that you can enumerate? There is transfusion associated circulatory overload. Now, transfusion associated circulatory overload is a term for fluid overload, right? When you give transfusion, there can be circulatory overload. It is just fluid overload, but transfusion associated, it's called as TACO. It's called as transfusion associated circulatory overload. This is the first thing that we have a problem with. The second thing that you have a problem with the transfusion is transfusion related acute lung injury. Okay, this is unlikely that this is fluid overload. This is just lung injury. Lung becomes leaky, and that's the reason that patient goes into a respiratory problem. This is transfusion related acute lung injury, and usually this is time bound. So usually it should be within 5 hours of a transfusion. That is when we call it as a transfusion related acute lung injury. Okay, then the third thing that you can have is transfusion related immunomodulation. Okay, immune suppression. So it's an organ after all. Since it's an organ of another person going inside, there can be immune suppression. Okay, so remember this: when you get a blood transfusion, immunity is known to go down. Okay, so blood transfusion can cause transfusion-related immunosuppression. So we know that patients who've received multiple blood and blood products, they have a chance of higher infection in the later period of life. Okay, the later period of the admission, they have a higher chances of having infections. Okay, so their immunity goes down. So transfusion-related immunomodulation is there. Then you have transfusion related graft versus host disease. So when you have transfusion related graft versus host disease, it could be in the immediate period or it could be later on after a couple of months also. Okay, so you could have it immediately or you could have it after a couple of months also. So there are multiple reasons which we would say which can be, and it can also cause an increase of infections, right? Like for example, every blood bank doesn't do something called NAT testing. Okay, when you have HIV and all these things, this is one of the biggest problems, right? But there's a window period. In the window period, the patient can still transmit an HIV infection. Now you understand? Understanding this? That window period, to lessen the duration of the window period, we do something called NAT testing. Our hospital does NAT testing. Okay, but every hospital doesn't do NAT testing. Alright, we do NAT testing to reduce that interval period also. Are you understanding? So transfusion can cause the spread of infections like Creutzfeldt-Jacobs disease. Like Prion disease, like things like that can be also spread with a transfusion. Okay, so transfusion comes with its own set of problems, and that is why 30 years ago, people have been trying to avoid a transfusion. They have been trying to do things, and then if you're left with a condition where you have a Jehovah's Witness, where you can't give blood, okay, there again, it's a problem to understand whether we can actually leave it at that or whether we should really give him the blood. Ethically, it becomes an issue, right? Whether give the blood or not blood if the patient is actually bleeding in front of you. Right. So that's the reason that a very bright intern called as Herbert, okay, his name is Herbert. Herbert in 1999 came up with a study, a very bright doctor who looked at 800, 900 patients of mixed ICU patients. And what he did at that time was he actually went and figured out whether restricted versus liberal transfusion, that is a 7 hemoglobin target versus a 9 hemoglobin target, will that make any difference, any kind of difference in a mixed surgical medical ICU patient population, like the ICUs that we have. What he did, he gave a group of patients when their hemoglobin reached 9, kept them at 9, and another group of patients he kept them at 7. And to his surprise, what he found, and to the surprise of the whole world, what he found was the fact that 7 was equal to 9. 7 was equal to 9. If 7 was equal to 9 on every aspect, then you definitely want to use the 7, because otherwise you're putting this patient in this category of patients. Isn't it? You're avoiding this category of patients because you're now putting the patient in a restrictive transfusion protocol. So this was called as restrictive versus liberal transfusion protocol, which was done by Herbert. And then subsequently there was a number of studies that came in, and Raskin Villanov basically came and said the same thing, and actually improves mortality too, long-term mortality too. So why was this in the first place? Why was the thinking? Why was the thinking that you needed to give hemoglobin? What do you think was the thinking? What is the thinking to give hemoglobin? Elizabeth, what is the thinking you feel to give blood?
One is they lose their reserves as the hemoglobin falls
Okay.
below the trigger like 7 and less.
What reserve? What are you talking about? What is it? What are you talking about? What do you think? Why do you want to give blood, Sachin?
Delivery of oxygen to the tissue.
Do oxygen. So what is the delivery of oxygen?
Is HB into
HB into
1.34 into HB into SaO2.
1.34 into
SaO2
into SaO2 into
plus PO
PaO2.
0.003 0.003.
That's it. This is not the delivery.
This is CaO2.
This is CO2. So what is the delivery? Delivery is when this is multiplied by cardiac output. Okay, so delivery of oxygen, you must know this equation by heart. It should be there in your brain. You can't mistake this. Your exam going, you can't mistake this. It's very, very wrong to not know this, because then I feel that I don't know anything. You understand? Huh? Because this is the basic funda behind everything that we do in medicine. Okay, we always try to improve oxygenation to our patients. That is what we do. Our basic funda is that. Okay, so if you don't know not those infections, it's very bad on your part actually. Okay, so this is a combination of a hemoglobin 1.34, which is the amount of oxygen that can be bound to that hemoglobin, into the saturation, that is amount of places that can be saturated with hemoglobin, plus PaO2 into 0.003. Now tell me a few things when you look at this. What do you think about this part of the equation? What do you think about this part of the equation? What do you think about this part of the equation? When you look at this part of the equation, if I keep my PO2, normal PO2, 100, 100 is normal. So 100 into 0.003 is how much? 0.3. So this fraction is very small, no? This fraction is very small. Do you think that this fraction is very small all the time? So I'm going to omit this out, right? This means I can omit this out from this, right? Because if it's just 0.3, I can really omit that from that particular side. What is the important fraction of all of these numbers? What is the important part of all these? If I tell you one thing, cardiac output. Cardiac output. So this is very important. Cardiac output. So in short, if your cardiac output, if your hemoglobin is even 2, or even if your hemoglobin is 5, if your hemoglobin is also 5, okay, I don't have a big problem unless my SaO2 goes down. You understand? PaO2 is not the problem. You understand? PaO2 is dissolved oxygen. Okay, so PaO2 doesn't become a very important fraction in the delivery of oxygen, and that's why a basic pulse oximeter is a better guide than an ABG. That is why basic pulse oximeter is a better guide than an ABG. You don't have to look at an ABG to look at oxygenation. It is not something you have to look at. Okay, and that is the reason that even when you're dealing with big protocols of ARDSNet and things like that, you actually look at saturation, because saturation is one of the most important things, right? So here saturation becomes very, very important. SpO2. So if I want to put this in the equation, write down the delivery of oxygen that you have in a normal individual, 70 kilos. Calculate and show it to me on the screen. So let's put the hemoglobin.
Around 8, 9.
Bus, don't add that because there's negative, there's not hardly anything. Into cardiac output, say 4 liters. Calculate quickly, someone calculate quickly.
What is 8, na?
92 times 9.
कितना आ रहा है?
Into 1.34.
134 into 136.
What is SaO2?
5,000 आएगा
4,820.
4824 टोटल अराउंड 5,000 आएगा
4824.
5 लीटर आएगा
4,824.
Are you okay with this?
Sir, it is 4824.
Are you okay with that?
the delivery of oxygen?
Are you okay with that?
It comes in ml, sir.
Exactly.
ml.
So what are you looking at?
Oxygen will be on 1.34 ml.
So are you wrong then? Are you really wrong on this? So that's why when I put this equation to anyone, nobody is able to answer this equation because you don't know what you're doing only. You just know ऊपर से. हाँ? कुछ आसान नहीं है लोगों को. Basically you should know this equation because this is a funda. When I first joined into medicine, no, my teacher told me if you don't know this equation, don't even join medicine. He told me like that. Don't even join critical care. This is what he told me. Dr. Shekhar Didi. He told me if you don't know this equation, don't even join. He told me like that. Okay. So this equation is basically going to get the units right in the first place. So what is this unit here? Liters. Very good. Liters per minute. Right? What is the unit over here? So it has to be grams per liter, not grams per deciliter. Okay, it has to be grams per liter. This one is saturation, which is a percentage. So it can't be 100. It has to be point. So what does this come into? Say let's take this as 10. This would be 1 gram per liter. Right? Into 1.34 into 0.1. 1%, no, it is 100%, so 1. You understand? And then you multiply this by 4, then you will get the equation that is right. You are understanding? Others you will not get the equation right. What is people calling me on this?
0.36.
No, we have to convert this to gram per liter. So this will be say 100, this becomes 100. Right? Gram per DL, no? Liter to convert into 100. Liters will go on top. Huh? 100%. 1. So when you now combine all these things, you will get an saying somewhere around 1000, right? 4.
So 100% का 0.1 क्यों नहीं है?
But that's a percentage. It's a 100% means 1% saturation. समझ में आ रहा है मैं क्या बोल रहा हूँ? It is 1 time saturation.
1 time से.
हाँ, so हो गया 1. So is that it? So when you do this,
1 sir, 0.1 नहीं होगा.
1 आएगा 1. 1.
100%
100 is 1. हाँ, so 1. So 1 आएगा. So once you do that, you get an answer of around 1000, 1200. This is what you're going to get. Okay? So if you put this whole thing together, your delivery of oxygen will be somewhere around 1000. Okay, now why am I putting this in place? For you to make you understand that the improvement in saturation is much more bigger than the improvement in HB. The improvement in saturation becomes 1, 2, 3, 4, 5, 20, 30 it will become. This improvement in saturation is much more bigger than improvement in hemoglobin, and that is the reason that targeting a hemoglobin of 10 grams per DL does not really improve oxygen delivery per se. You understand the first thing? Just targeting a saturation would be better. So rather, if your hemoglobin drops down to 2 or 3 or say 4 or 5, that is when your hemoglobin will come into picture. Okay, but if it is 6 and above, you can very well assume that this oxygen delivery will not change. समझ में आ रहा है? Your oxygen delivery will not change. Understood this? The fraction that is here is much more bigger than the fraction that is here.
Sir, MCQ वगैरह है तो क्या है आंसर करने के? There was one MCQ.
हाँ.
The HB was the correct answer that they had given.
No, so in this equation you must understand saturation is always better. You see obvious ना? अगर मैं इसको बढ़ाऊंगा, इसको 50 करूंगा, 60 करूंगा, तो this equation become bigger here. Hemoglobin is in points, no? If you want to make it grams per DL, it is 1, 2, 3, 4, and then you multiply it by saturation, it becomes bigger. You got the points. Saturation becomes much more important here. So in delivery of oxygen, this is very important. But this in critical care, this part also becomes important. Okay, now if you want to look at this, if the total delivery of oxygen is say content of oxygen is 1000 ml. Here if you look at this is 1000 into 4 will make it 4000, right? 1000, right? And the amount of delivered oxygen will be barely around 1 to 3%. Point है कुछ तो भी. So 1 to 3%, right? It is not going to be very high. समझ में आ रहा है? This is not going to be very high. It's going to be 1 or 3% of the total that you're having away. Hardly anything will be there. Even points में होगा वो. Barabar. But what happens is when a patient is critically ill, this percentage also becomes very important. It slightly increases. Dissolved oxygen also goes up slightly. You understand? Dissolved oxygen goes up. So moreover, if you're going to give hyperbaric oxygen, this again goes up higher further. That's the only time when that dissolved oxygen comes into place. Otherwise, usual scenarios, the dissolved oxygen will not be in anything that is concerned. Right. Now let's take an example. So now you understood this much till now? Huh? So based on so oxygen delivery is not equal to hemoglobin. This is what I'm trying to tell you. The oxygen delivery is not equal to hemoglobin. There are many more things that will help the oxygen delivery, of which one of the important things is cardiac output and saturation. Samajh mein aa raha na? Clear? So now let's go to what do you do with a patient that comes to you, right? So you have a patient that comes to you, hemoglobin is 8, is 8 in front of you. If the patient is bleeding, there is nothing to be thought. That is exsanguination. When there is exsanguination, there is nothing to be thought. If the patient is bleeding, his hemoglobin is 9, if it is 8, if it is 7, you give the blood. He is exsanguinating. Exsanguination means what? He is actively bleeding. But if you leave him like that, he will die. For example, an artery is ruptured. For example, a varices is ruptured. For example, something is bleeding because he's had a trauma. There, the hemoglobin doesn't matter. You have to give the blood. So everything is going down. You need to give that blood. So transfusion triggers in massive transfusion protocol or transfusion triggers in exsanguinating bleeds are not part of anything. There is no trigger in that. You give it. So for example, the varices patient, his hemoglobin is 9, we give him the blood because he's exsanguinating. He's exsanguinating. You leave him, he'll probably drop to 5 or 4 very quickly. So there is no trigger there. You are just giving it. For blood, plasma for plasma, platelet for platelets. That's why we give 1:1:1 for these patients. Right? That is massive transfusion. So we are not even talking about massive transfusion here. We are talking about transfusion trigger. We are talking of a patient who is in the ICU. He basically came for an ARDS. His hemoglobin was 7. What do you do? Or his hemoglobin was 8. What do you do? So let's take the example of a patient who came into the ICU. He had sepsis. His age was 70 years old. He was on a vasopressor and his blood pressure was 120/80 and he had a good heart. Urosepsis was there and his hemoglobin came out to be 8. What are you going to do now? This is the question. What are you going to do? How are you going to investigate? Let us put it this way. How are you going to investigate this patient? I am not worried first of all. Why am I not worried?
Hemodynamics.
8. We just discussed. The delivery is there, hemodynamics is stable. I'm not really worried. Okay. But he's sepsis patient. What do I do here? If I want to investigate this patient, do I investigate in the first place?
Also to see his baseline sepsis related.
Do I investigate? Like for example, I'm going to investigate sepsis, but do I investigate his hemoglobin? That's the question that I'm trying to answer. And if you want to investigate, what do you do? So Saqib says iron studies. Anybody?
Rule out any active bleeding.
Rule out?
Active bleeding.
उधर देखो हाँ
Sorry. Any bleeding.
Bleeding.
There is hemolysis.
हाँ
Hemolysis.
hemolysis. So you want to investigate. So इसमें तो बहुत सारा investigation आ जाएगा. मतलब what do you want to do? So tomorrow if I come with the hemoglobin weight, able to send 50 investigations on my body. How is it? How are you going to deal with such patients? How are you going to deal with such patients? That's the first question is it going to make a difference if I go give the blood? No, it's not. That you've understood. I don't really require to give blood. That is first thing. I don't require to give blood. Do I investigate? So how do I investigate and what is the way you want to investigate? So first of all, you should know the previous hemoglobin if there is. Or you need to find what is happening. So if today it is 8, tomorrow it becomes 7. That's a 1 gram per DL drop. Right? If yesterday it was 9, today it's 8. It's a 1 gram per DL drop. Yesterday it was 8, today it's 8.5. Doesn't make a difference. 8, 7.5 doesn't make a difference. Drop by a gram per DL will be indicative to trigger for an investigation. You have to investigate if the hemoglobin drops. I'm not going to send an iron profile for this. And why do I don't want to send an iron profile? In any chance, anyways.
70 age also.
So let's take the example of anemia evaluation. Okay, now that we have this already in place, anemia evaluation. What do I do? Anemia. What do I evaluate? How do I evaluate anemia? What do I do? What is my first investigation here? CBC will give you the anemia. It will give you the hemoglobin. What do you do next?
MCV
How do you investigate an anemia? Okay, you do an MCV, you get an idea, okay, something is wrong. What do? You did a CBC, you saw what hemoglobin is low. Now what do you do? How do you investigate anemia? What is the first thing you do here? What will happen when you have low hemoglobin in your body? What should happen to your body? What cells will increase? What will increase? Yeah, the first thing what should happen is reticulocyte count should increase. That is the first thing that should occur, right? So ideally I will do what? Ideally we will do a retic count. Clear on this? What does a retic count indicate?
Increase production.
What does it indicate?
Increase the production.
If your body is dropping hemoglobin and if your marrow is healthy, your retic count has to go high. Simple. If your hemoglobin is dropping and your marrow is healthy, the normal response of the marrow is to increase retic count. Is that simple? If you, again I'm repeating, if you have anemia and your marrow is working properly, what should happen to your retic count? Simple. This is simple, right? A retic count should increase. That is why my first investigation would be a retic count, which will actually give me whether it is more than 2.5 or less than 2.5. Okay, more than 2.5 or less than 2.5. Clear on this? The first investigation, right? Now let's take the example that it is less than T or 2.5. If it is less than 2.5, what are we dealing with? There's something with the marrow. Either the marrow is diseased, but for some reason that is either hypoproliferative or it is infiltrative. Either the marrow is proliferating less, or it is infiltrated by some fibrosis, some leukemia, something infiltrating the marrow, some disease of the marrow, maybe an iron deficiency which is causing this, a B12 deficiency that is causing this. You understand? An iron deficiency will cause the marrow to produce less hemoglobin. It's hypoproliferative. So here what am I going to do? I'm going to do a macrocyte. What is the size of the RBC? Once I come here, up to then I will do what is the size. Is it microcytes? It is macrocytes. And based on that, I will look whether the marrow is down, B12, folic acid, iron, or maybe there is a cell defect. So if the shape is not okay, thalassemia would come in place, sideroblastic anemia will come in place, membrane defects will come in place, cytoplasmic defects will come in place, nuclear defects will come in place. Understanding? If the patient reticulocyte becomes low, I am going to look at morphological problems that might occur because the membrane of the RBC is not okay. Or maybe it's not forming a proper cytoplasm, not forming a proper nucleus because folic acid is not there, because B12 is not there. You understanding? Or it is infiltrative by some malignancy or things like that. Or there is sepsis which is causing the marrow to get depressed. Right? And marrow depression can lead to anemia. Now let me take you backwards. Okay? If you have a patient whose marrow, मैंने आज विनोद का marrow ले लिया और उसको मैंने बंद करने बोल दिया. Stop it. Don't produce. What will happen to hemoglobin? Today I am God. I tell Vinod, your marrow should stop from today. Production of anything. What is going to happen tomorrow? So hemoglobin is 9, and I told his marrow to be stopped. What is going to happen tomorrow? What is going to happen to this 9? It will drop only by 1%. It will drop only by 1%. So 1% of 9 is 8.9% or 8.9 होगा. It will not drop from 9 to 8. It will drop from 9 to 8.9. Even if I shut the marrow. Right? So in short, what I am trying to explain to you that a hypoproliferative marrow or an infiltrative marrow will not drop your hemoglobin from 8 to 7. Will not do that. Are you understanding? It will not do that. So is there a point of investigating iron? Is there a point of investigating B12? Is there a point of folic acid? No, in acute anemia, no. There is no point. Absolutely no point. समझ में आ रहा है? Are you clear about this? And why is it also absolutely not required to be in intensive care? Because iron is not going to improve this immediately. It is not. Iron is something that is intolerable. At the same time, it causes an increase in inflammation. So if you give iron, it actually increases inflammation. So I don't want to do anything that will increase inflammation, isn't it? It's not something I want to do, right? Iron is intolerant. So we send patients only when they are chronically anemic. So we don't send to all patients. So what I heard you say that all patients. So you don't do it to all patients. You do it only to those patients whom you feel has chronic anemia and non-septic. You understand? Because anemia, sepsis itself will actually drop your proliferation of your bone marrow. समझ में आ रहा है मैं क्या बोल रहा हूँ? So is there a point of doing this side of the protocol? No. Clear? Clear? There is no point of doing this side of the protocol. We need to do this side of the protocol, which is this side of the protocol where the reticular count is more than 2.5. And this is where all your problems comes in with respect to either first thing is acute blood loss and second thing is hemolysis. So we for ICU investigation of hemoglobin, it's very simple. We have only this part of the story. Okay, for ward admission, you have a whole lot of shit chat to be done. But for ICU admission and you have a hemoglobin drop, you have only very few things that need to be done. Which first you understand is acute blood loss, and the second one is hemolysis. Clear? Simple. And for hemolysis, what do you send? So you like to send things that cause hemolysis, of which one thing is simple thing is LDH. Coombs test, direct Coombs test. Coombs test. And smear. And haptoglobin. 3 tests to be done. Very simple. One haptoglobin, one LDH, and one Coombs test. This will tell you about hemolysis, provided it is the context of hemolysis. If there is a clear-cut context that this patient having stool for occult blood, will you send all this nonsense? Stool for occult blood is positive. I have acute GI bleed. I just know I don't need to do anything. It's an acute GI bleed. Understanding? Because the average lifespan of an erythrocyte is 120 days. So don't expect the erythrocyte to die and drop your hemoglobin. वो नहीं होने वाला है. You understand? That is not going to happen. ठीक है? Clear on this? So ICU anemia evaluation is very simple. Okay.
The hemolysis will also come in chronic only.
It can be. So in this part it can chronic, but this will also be involved with marrow issues. You understand? But acute hemolysis, when you're saying, what you're asking is there acute hemolysis? Yes, there is. For example, you have an impeller device in place. Now what is an impeller? It's a device that goes from inside and helps the heart to pump. You have a IABP in place. It's a device. You have a mechanical heart valve in place. This is all hitting the blood so hard it is hitting the blood that the blood gets hemolyzed. You have malignant hypertension, extremely high blood pressure, 220, 230. Okay, that can cause, because of the sheer effect of pressure of the blood, it can cause the RBCs to rupture. Right? Those are all part of hemolysis that can occur in such cases. Are you understanding? You can have clopidogrel or drug-induced hemolytic uremic syndrome, where you have maybe a drug that you have given and the person has gone into hemolysis. You understanding? You could have sickle cell crisis. You could have G6PD. These are all acute episodes. For example, you have a patient on G6PD and you give him a drug that is not supposed to be done. Primaquine. And fat karke patient goes into hemolysis and you have hemoglobin dropping the next day. So you will have series of acute hemolysis that will occur, which you have to rule out. That is why I said in the context of the illness. That's why I said in the context. So look at the context as to what is this patient doing. So what do I need to send? As you are a first clinician, then only investigations. You don't send 100 investigations to find an answer. You send 2 investigations because you have something in your mind. You understand? If you're going to send a whole battery of investigations, means you don't know what you're doing. There's no clinical work only there. It's mechanical work, right? If you want to really figure out what you're having, you have something in your mind. I think this is what the problem is. Hence, I want to send this investigation. That's how you're going to put this over here. If I'm certain that there is nothing on this part, I'll just send a stool for occult blood and figure out what's happening here. So acute blood loss is something that is occurring. One of the commonest causes of acute blood loss in the ICU is venipuncture. Okay, venipuncture. So on an average, we send around 40 to 45 ml of blood per day when we are actually doing investigations, and that is why at the end of 4 days, one person gets a blood transfusion. At the end of 4 to 5 days, a person generally invariably gets a blood transfusion. There are many reasons why a patient in the ICU can actually have low hemoglobin. One is the blood draws that you have for various investigations that you send. They actually do 45, 50, 60 of blood draw every time, right? The other reasons are because of the fact that you have an inflammatory tendency, which is basically dropping your marrow. That's why iron and all doesn't work, because marrow itself is not working well. And that's why we don't give iron in our ICUs, because we feel it is not going to help, because marrow itself is hypofunctional. If marrow is hypofunctional, iron देखिए मेरे को क्या फर्क पड़ने वाला है? If I have a documented iron deficiency with the marrow that is functional, then I give the iron the marrow will produce the hemoglobin, right? So that is why if tomorrow you have a patient with low hemoglobin, I can't help by giving erythropoietin, it's not going to work. Because if you have background iron deficiency and then you give erythropoietin, then in a patient of renal failure it will go on. समझ में आ रहा है what I'm saying? Huh? You understanding what I'm saying? Huh? So people might think, "Arey yaar, no, I have low hemoglobin. Let me keep giving erythropoietin." It will not work. It will work only if iron deficiency, transferrin saturations have to be high. Iron deficiency has to be there, right? Then it is going to work. Otherwise, there is no point of giving erythropoietin. So erythropoietin is completely out of the equation in ICU. Iron sucrose is completely out of the equation in the ICU because of inflammation. I don't want to do that. It really doesn't help. Iron tablets is something you may or may not want to give. It causes intolerance. So in a person who's having intolerance, first stop the iron. In a person who's having intolerance, first stop that iron. You understand? So iron is something that probably may not work in such cases. But we give it in our hospital for the folic acid because we have folic acid deficiencies that are there, which has other features, not for anemia. It's other reasons why you want to give that folic acid. It's got other reasons why you want to give folic acid. समझ में आ रहा है? You understand? Iron is not going to get your hemoglobin up immediately. ठीक है? So clear on this? Clear on this algorithm now? So now in this particular patient, sepsis is 70 and hemoglobin is dropped, then only you will send investigations, right? What is that? Just a minute. Variceal bleed. Say I want to give the blood. What is the problem with the variceal bleed?
Sir, portal pressure.
Will go up, no?
Yeah.
You give blood, portal pressure will go up. So it is easy to give for variceal bleed after you have secured. After you have secured the varices, it makes sense to actually give some amount of blood. But that's the problem with giving blood also. In a variceal bleed, you give blood, portal pressure goes up, again it bleeds, again the patient exsanguinates, it becomes problematic. That's why I told transfusion triggers specifically are not there for exsanguinating patients. That is completely dependent on the context at that particular moment. You have a patient who comes in with who is going in for a massive surgery of his vascular extremity. I won't give the blood at that particular moment. Let him go to the OT. Let him first get the tourniquet. Let him first finish then you give the blood. When you have a patient who's having hemoperitoneum, I don't want to go and give him the blood, though he is bleeding into that, because I want them to first secure the bleeding inside, then give the blood. So there are contexts. Exsanguinating bleed cannot be equated to this. You understand? So here we are dealing completely with respect to a patient who's in the ICU, becomes 7 to 6, and what do you do? This is what you're looking at, right? So now comes to the question: what will be my trigger? So what we know now from Herbert's trial is that 7 was equal to 9. That is the first thing. Have you understood this?
Yes.
So for all practical purposes, for all ICU patients, hemoglobin 7 should be your transfusion trigger. Okay, hemoglobin 7 should be a transfusion trigger, excepting when you have a patient who's having active myocardial infarction or CABG. Active myocardial infarction, that means active angina or myocardial infarction. It can't be a patient with ischemic heart disease. If a patient has ischemic heart disease and is admitted in the hospital, his hemoglobin of 7 is acceptable. But if it's a ischemic heart disease who's having active MI or having angina or a CABG, that patient has to be maintained at 8 to 8.5. Right? 8 to 8.5. You can't go lower than that.
If is CABG, then around 8.
8.5 Q per.
CABG.
Yeah, CABG, active MI, active myocardial infarction, and angina. These are these three places where not ischemic heart, not just ischemic heart disease. You understand? These are the patients in which you want to keep the hemoglobin 8.5, primarily because what they found, why it is like that is probably because of a literature. What happened is Herbert when he did his studies, and all the people who did the studies, they excluded those patients from those particular analysis. They didn't look at those patients at all. Since we don't have data, the evidence is not very clear for those particular patients. We don't want to go down on those because we want to keep them on the higher side on those patients. Right? It's not got to do with delivery of oxygen or things like that. It's just related to the literature probably. Okay? Yeah, Darshi? Right? So understood this? So transfer trigger is so this is the end of transfer trigger. There's nothing more than this. This is the transfer trigger. 7 and 8.5. That's all. You understand? There's nothing more than this. But you must understand why it is like that. समझ में आ रहा है? Clear? Any doubts?
So destruction of RBCs also, cystocytes we send.
Yeah, so that's DIC, that's hemolysis. This goes to this side of the story, So this side of the story. That is, if there is on that side of the story, there's DIC. You will send investigations as per the context. Okay. So once your LDH goes up, you know for certain that there's hemolysis happening. It's as simple as that. LDH becomes very important in these cases. That's why we send LDH to understand what is happening. Sometimes it does happen, there's hemolysis, and that's the reason that we do that. Okay? Any queries on transfusion triggers? So you should know few names when you're in exams. Herbert trial, that's called the TRIC trial. TRICC, Transfusion Requirements in Critical Ill, TRICC, 1999. You should know that trial, it's very important. Okay, very, very important, because that's what completely put the benchmark on transfusion in critically ill patient. Okay, so that trial, you before your exams, read it a little bit. ऊपर से पढ़ो उसके बाद TRIC trial क्या होता है, because it's important for your exams. ठीक है? Anything further on transfusion trigger? Okay, so I shall stop this up. So we can break for now.